one of the things that I think, and I accept complete responsibility for this, that we've neglected in the past couple of years at our developmental disability rounds is the role of dentistry. And, among patients that we see, first of all, we know there's a high rate of dental problems, but also I think often real difficulty in getting people even being able to be examined at times. And so it's an area that is incredibly important and we've neglected. So for that, I apologize, but I am hoping to make up for it today in a big way. So our guest is Dr. Raymond Lee, so Raymond grew up in Waterloo, received a Bachelor of Mathematics from University of Waterloo, and then went to Western where he received his Doctor of Dental Surgery. Raymond then completed an internship at the Hospital for Sick Children in Toronto and pediatric specialty training, which included a diploma in pediatric dentistry from U of T. Also has a Master of Science from the Hospital for Sick Children in Toronto, and a fellowship in pediatric dentistry from the Royal College of Dentists of Canada. Apparently, Dr. Lee is an eternal student because in addition to now being a fellow of the American Academy of Pediatric Dentistry, he has started his executive master's in health administration from the Tefler School of Management at the University of Ottawa. You haven't started it? Or?
It's crazy. Yeah, I started it.
Well, it is. Yeah, it's very busy. But so Dr. Lee is also, as the slide says, the pediatric dentist and the co-site chief at Children's Hospital for Dentistry, and has been an adjunct clinical professor in the School of Medicine and Dentistry at Western since 1995, and has been a staff pediatric dentistry there since 1997, and the site chief since 2008. But I don't want to say more important thing, but whenever I talk with patients of mine who've seen Dr. Lee, what I tell new people who are saying they have appointments coming up with Raymond is that the absolute worst thing I've heard about Dr. Lee from any patient is that he's fantastic, is the worst thing I've ever heard. So I think people speak glowingly of Dr. Lee and his ability, especially with kids that we see with disabilities. So I hope I haven't raised people's expectations too high for the talk, Raymond. But thank you for taking the time and thank you for joining us. We really appreciate it.
Thanks for having me. And I don't know what to say to that. I usually say to the parents, you got the best pediatric dentist here. You also got the worst one because I'm the only one. So in reality, I'm somewhere in the middle probably. So I'm going to keep playing. Thank you for all that. Sorry to make you read all that. Nope. You forgot the part I'm a Capricorn as well. And so bold on the outside, scared to silly on the inside. And I always try to do the right thing. Right. So that's a big thing. So. And I think the best thing about that is I was also supposed to be an old young guy and a young old guy. How's that? And suddenly I'm one of the old guys now. So I keep fidgeting with my glasses too here. So my ADD, my anxiety here is showing up because I can't see anything, but the glare off the glasses is kind of annoying. So I'll try to make this, and I apologize to the dentists out there because the first half is about dentistry. I just wanted some basic things, not to teach you all about dentistry and all the years of travel and the education I've had, but you have to understand some of the basics of dentistry in order to understand what we're trying to get to. So hopefully we'll meet those objectives that we sent out before, and hopefully you have a little bit of understanding of it, of what I do at least, what we try to do. There's always room for improvement, but I don't lower the bar for any patient. I always aim high, hope for the best for all of them, plan for the worst, but hope for the best. We always try to do what's best for the kid. And when I say kids, I mean the adults as well. All these patients are just kids to me. So I start off with this slide with every lecture because this is Victoria Hospital. I don't know if anybody can see my cursor there, but this is the big, beautiful hospital here. And then over on the left, there's B Tower. That's where Children's Hospital is. And I always kind of joke that if not every hospital has a dental department, but if they do, it's usually stuck in the basement somewhere and you can't see it. But in this case in London, it's way over to the right here and you can't even see it. So it's in the oldest part in the professional block. So I don't know if that's just saying anything about dentistry in general, but we've been there since we moved over from South Street in 1989. If anybody in London remembers South Street, we have cracks in the floors, but no holes in the walls. So we could really use a $5 million donation to rebuild the clinic, but we don't. We make do with what we have, and we have good people, and we provide a good service. I think do the best we can. So, special needs dentistry, some basic. That is a pun on words. Tooths. It wasn't molars. Somebody asked me molars. Is it some basic tooth? Excuse me there. I don't have any disclosures to give, or there's no conflicts of interest. So what is a pediatric dentist, and why is the pediatric dentist talking about these special needs kids? or adults with special needs. Just a quick definition is pediatric dentists, we kind of deem ourselves as the pediatricians of dentistry. And that's the best analogy that we have. We limit our practice to treating infants and children through adolescence. But I think where the big difference is in medicine and physicians versus dentists is that pediatricians, medical pediatricians, physicians, they stop at 17 and under. But the pediatric dentist, by definition, our specialty includes the special needs patients of all ages. And that's where it's a blessing and a curse, because it opens up a whole can of worms for us. Because there really is no place for, if in physician world and medical world, if you turn 18, you go see an adult doctor. But in dentistry, there is no equivalent to that. So a lot of times, except for the general dentist, and that's where we get stuck, because not every general dentist is comfortable or able to, or they don't feel they're able to see these patients with special needs. And so a lot of times it falls back on us as pediatric dentists. And I'm just kind of guessing that's how that happened, because we all have big hearts, but these kids need to be seen. And if they saw us at 17, it doesn't really change anything at 18, right? You still have cerebral palsy, you still have Down syndrome, you still have a seizure disorder, what have you, right? So I would rather see an overage patient than have them not be seen at all. We're dedicated to the oral health of children, especially. Sorry, I apologize for reading the stuff to you, but some of the mundane stuff. But the second point is that the very young, the preteens, and the teenagers all need different approaches in dealing with their behaviors, guiding their growth and development, and helping them to avoid dental problems. And this gets to the gist of the problem, or the gist of how we function, is that we can talk about teeth all we want, because after a few years, not to be arrogant about it or confident about it, I guess, is that teeth are teeth. It becomes very mechanical what we do. But as I teach the residents, it's all about the person attached to those teeth that you have to deal with. And we all know that. It's about the person, their personalities, their behaviors. That's the hard part. Because in the end, if you just look at the teeth, it's kind of mechanical after a while. There's only so many things you can do to a tooth. You can look at it, you can fix it, you can take it out. You see a hole, you clean the hole, you fill the hole. And not to make it that simplistic, that 9 years of the university got there, but I think it's the challenge is to deal with a person. And I think they appreciate that, whether it's the parents or, and again, you got the kid, you got the patient. With every kid and patient, there's a person attached to them, so the parent. So in the pediatric world, we call that the pediatric triangle. It's not just you and the patient, but there's also a caregiver there, whether that's the parent or the support staff. We all have to be on team and on the same page together. And to the last point, and that's just in general, that's up. And the last point, if you have special needs, you often have additional unique emotional, physical, and/or intellectual challenges that we have to include in our decision-making, how to go forward and fix these kids. So nothing like a pediatric dentist to do that. And these are general, apple pie things. Good oral health is an important part of total overall health. I came up with this the other day. If your eyes are the windows into your soul, then the status of your mouth and the health of it is kind of an indication of the status and the health of the rest of your body. I don't know if I made that up or I heard that somewhere, but you got to start somewhere right here, and that's got to be healthy. Otherwise, your body's not healthy, because you got to be able to eat, obtain sustenance. And if that's not good, it's a bad start right from the beginning. As you can imagine, a lot of these slides are about pediatric dentistry, and I kind of kept this slide in here because we often get, as pediatric dentists, well, why bother with the baby teeth? They're all going to fall out anyways, and that's an ongoing pun of mine, is that all my work eventually falls out in little kids. But it's just the points about why your teeth are important. You're used mostly for eating, good nutrition. You want to eat well. And if anybody who's had a toothache knows, you got a bad tooth when you can't eat and you can't sleep, and that's agony. Some moms have said it's worse than having a child. So it's that it affects your quality of life. If you have teeth or you don't have teeth, it affects the way you speak. You want proper spacing. If you're missing a tooth, the adjacent teeth will start to move, and that again, cycle back. It affects the way you chew, the way you bite, the way you speak. Normal development of the jaws and muscles. Constant. This is a ballet, I always tell parents. The way you chew, how the tongue pushes the food onto the top of the teeth, how their cheeks keep the food onto the teeth, and that's how you chew and bite. Now, if you're missing teeth, that ballet is all over the place. So there's proprioception in the nerve endings. And so on top of that, if you have some developmental disabilities and that's discoordinated, is that a word? It's not coordinated, it increases the challenge. And that's why you need to keep your teeth as long as you can. And again, and the last thing, of course, self-esteem and appearance. Let's face it, we all judge each other in the way we look. And so you have that smile and you're missing a front tooth, you're judged. It's just the way human nature is. It's not meant to be mean or negative in any way, but we're all judged by our appearances, whether it's you have a tooth or not. But you can imagine some of these kids with special needs, they already have some dysmorphic features, and if they're missing teeth in the front there, that just adds to the situation, unfortunately. And that's just the nature of the world. But I keep that, that's why teeth are again, apple pie stuff, So after 25 years in the hospital here, and I just got my long service award, so I can't believe it's been 25 years. I was a young puppy then, but there's still some people in the hospital system that in London that we have a dental department. They're still unaware of what we do, so which might be a good thing. I don't need to advertise, and I think it's important that we're there when we need to. But these are stats that we see that I have from. I took it from 2018 to 19. Only because 19 to 20, that ended up being the pandemic and COVID, right? So everything that's COVID has become a bookmark, so to speak. Everything's pre-COVID or post-COVID. But we routinely see, and this is me personally, I probably see about 1,300 patient visits, or do 1,300 patient visits a year. We treat about 350 patients in the OR. Now, that's not just me. There's other consultants here in town that come in and use the operating room, and they treat patients that way. But again, we don't advertise, and I routinely get 25 patients a month easily. And that could be from referrals, it could be from Emerge, what have you. So we're busy. And that's only working, I really only work about 2.5 days in clinic and a day in the OR. And so the other days are admin and trying to catch up on life. Well, that's busy. I think I'm busy. And these a lot of the patients they're high needs too. So. But what do we treat? And again, not meant to be too simple in terms of dentistry, but I'm trying to, if you wonder what we're fixing and stuff, and it's not just kids, it's adults with special needs, everybody, right? But decay is number one. Patients come in, they have decay. Decay is the single most common chronic childhood disease, and the classic phrase that they have, it's 5 times more common than asthma. And if you think about children who doesn't have asthma, you imagine that, multiply that by 5, and that's who has cavities. There is a statistic out there, and I don't know, I know the reference, but I don't, but they say that every child that enters junior kindergarten or a senior kindergarten, so they're 5 years old, 46 to 48% of those children have already had a cavity. So it's that prevalent, it's that obvious, it's in our society. And why is that? Because the basic science of it is dental caries, cavities are caused by bacteria. We know it's a fact. So therefore it's defined as an infectious disease. Bacteria strep mutans. Everybody has this. As I give parents the quick lesson, 2-minute lesson about cavities, I suggest that the baby's born. When you're born, you're sterile. But as soon as the mom kissed him, her, the baby, they've inoculated them. Right? And so everybody has this bacteria. The reference is that only 70% of the kid's bacteria comes from the mother, which the joke is never 100% mom's fault, but that's where it makes sense because the mom's the primary caregiver. And because the strep mutans, it's in your mouth, it eats up sugar, and that's the key thing. It creates a biofilm on the teeth, and then that's where the plaque forms. And when the bacteria eats up the sugar, bacteria grows, creates acid. Acid is what dissolves your enamel and creates cavities. That's a very simplistic synopsis of it, and it's meant to be. So in theory, if you don't give somebody any sugar at all, and you're brushing like crazy to keep the bacteria down in the biofilm, and if there is a little bit of sugar, you're brushing all the acid away. In theory, you should never get a cavity. In theory, the classic example would be with a patient who's G-tube fed, totally 100% G-tube fed. If they're not putting any sugar, any food in their mouth, I'm not talking about just a lick of a birthday cake on their birthday or anything like that, but if they're not putting anything in their mouth, and technically they don't get cavities, and that's true. Right? Unfortunately, there's sugar in everything. What I call people that are non-G2 people, that they do take food. There's what I call bad sugars, and anything with the word chocolate in it is probably bad. Anything from Tim Hortons is probably bad, including the Tim Biebs Timbits. I haven't had one yet, but apparently they're very sweet. So, but there's also sugars in good things like fruit and milk and juice. And so you can't avoid sugar. I remember when I first graduated in 91, they told us that we might have to look for a second job because they're going to fix cavities, right? There's not going to be any cavities. And that's why I did a master's, because I could teach or do something else or do research or what have you, right? But if there's a great Netflix documentary on the sugar industry, sugar is here for life. And as long as we're intaking sugar, we got the bacteria, and they're not brushing as well as they could be in children, or if they have any disability, you're going to get a cavity. because there is genetic components in it, because if it's such just those two things, genetic component, there's no such thing as soft teeth, and enamel is pretty darn hard. Apparently it's the hardest substance in the body. It takes a lot of acid to dissolve that enamel. And I've always suggested that if a tooth is like a house, you got the enamels like the roof and the shingles and all that, it takes a lot of acid rain to come down and put a hole in that roof. And the joke is that it always comes back to climate change, I guess. I honestly think it's in your saliva. I think how much saliva you have. Again, drooly kids with cerebral palsy, the drooly, they could just wash all that stuff away. So they could eat 10 chocolate bars a day in theory, and then it just washes out. But it's in your saliva, it's in your enzymes, but who knows? Bottom line is that I have a job for life. These cavities are here for a while. Those are the risk factors. I left the nursing bottle picture in here just to show you what happens if you have sustained, frequent, and prolonged exposure of not just infant's teeth, but of your teeth to liquids containing sugar. This is what happens. If you buy into the story about the bacteria and the acid created, it literally dissolves the enamel. Now in babies, and if you're familiar with this, I'm assuming people are, parents put their kid to bed with a bottle with milk or juice or formula, what have you, because honestly, it keeps they like it, number one, it keeps them quiet, and then the parents can sleep too. But when you're sleeping, there's less saliva, there's less swallowing, there's less clearance. You're basically soaking the teeth wherever the nipple sits, which is right in the front teeth there. And this is what happens. So extrapolate this into a teenager who's playing video games and they're just dousing their teeth in Gatorade and Powerade. And you take this to an adult, whether special needs or not, they're drinking pop all the time, coffee, doubles with all the sugar and the acid in that, and doubles, triples, or anybody's heard of the Gretzky, which is the 99, where they get a coffee and they get 9 sugars and 9 creams. Like, ew, like there's very little room for coffee, but all that stuff is sitting on the teeth, and it's not brushing it away. It's causing that biofilm, causing the acid production, dissolving the teeth and causing cavity. And if there's nobody to watch it, their teeth are going to disintegrate. And I'm talking about the caregivers, the parents, and the caregivers, and the dentists on our part that we have to reinforce that. Well, that's just cavities. The other group of patients that we see is the medically compromised. We do programmatic support for all the other services in the hospital. That's just alphabetical order. I'd probably say the top 3, or the top 2 for sure, are the cardiology kids and the oncology kids, because there's known relationships with having bad oral health can affect kids with congenital heart disease, because that can cause endocarditis. Oncology, especially the kids undergoing chemo, where infection, a bacterial infection would not harm a healthy kid, but if you're immunocompromised through chemo, that could be potentially a life and death thing. I think in children, I think otolaryngology, ENT, is probably our third, probably most common collaborator to work with. But in adults, special needs especially, is orthopedics. Would you believe, I thought this was kind of, when I did the numbers, would you believe there's a lot of kids, patients, adults, they're getting their hip replaced or a knee replaced. Well, they got to have a clean mouth because they don't want any bacteria causing an abscess, going through their system, getting a low-grade bacteremia, and then affecting the success of that prosthesis. That's why we sometimes have to give antibiotics. So regardless of caries, regardless of their medical compromise, they could all be included in the special needs patients. The special needs patients we define as those ones with physical, medical, congenital, developmental, and or cognitive disabilities. And that's just a list of 8 random things that patients that we see. CP kids, Down syndrome, I love the new terminology, T21. They sound like Terminators, I love it. Developmental delay, chromosome genetic anomalies, of course the classic seizure disorders, autistic kids, behavioral, and of course the mental health. So those are kind of the ideas of what we do. So what are we doing for these patients? And if anybody comes, anybody can come down to Vic and see our clinic and see what we do. If the patient is cooperative, again, the person attached to teeth, if they're cooperative, we can just drill and fill teeth. If they're a little uncooperative, and a lot of these special needs kids are, we have to think about some form of sedation, whether that's laughing gas, nitrous oxide, or we use oral midazolam, which is a benzodiazepine. And I like midazolam better than Ativan. We usually ask medical people, their doctors, their physicians, to approve a benzodiazepine, because the midazolam is more meant for children. But I like the midazolam because it takes an effect within, Ativan takes probably about an hour to kick in, and the metabolites are active. So sometimes those patients are sedated for a day. I love midazolam because it starts within probably 15 to 20 minutes. And it's usually, the half-life is usually 2 to 4 hours and it's gone. Right? So it's a very short acting, and just just to get enough cooperation, controlled behavior that I can get things done. IV sedation is the next progressive one. IV sedation, I don't do that myself. I'm qualified to do it, but I usually ask my colleagues to help me with that. They're emergency physicians, or we have colleagues called CCOT or PCOT here, or the anesthesiologists. They come down and help us sedate the kids, the patients, and we do that. And general anesthesia, of course, is the go-to. Unfortunately, a lot of the patients, the adult specialties, we have to go to this because honestly, they're just too big and too complicated to just hold in the chair. But for a regular routine, to fix something like to fix a cavity or to take a tooth out, but we get by on oral midazolam a lot of times if we're just doing cleanings on the special needs population. So as long as they will drink it, it doesn't taste the greatest, but they're used to getting meds too. So general anesthesia, I can show you all sorts of horror pictures about teeth, broken teeth, abscesses, things like that. Interesting fact that the most common operation in children between the ages of 1 and 5 are for dental. I would have thought for tonsils and adenoids or something like that, but it's actually for dental. And that's from the CIHI, the Canadian Institute of Health Information. The numbers, the years from 2013, it's again a little dated, but it's not untrue. If anything, that number is underreported, I think, because it doesn't factor into the surgeries that happen in private offices. And I think that's growing. So you see a 3-year-old corny, as in corny, 3-year-old, he's only had those teeth for about 2-3 years and they're all disintegrated. I still see corny. He's about 25 years old now, and his adult teeth are way stronger, but it's taken a lot of years of trying to get him to brush. And he's cooperative to the point he has fun. And he's the 10th of 10 kids from a Mennonite family out in Tilsonburg. So it's always been a challenge, but he's been with me since he was a little guy, and he's much better now. Or this is Jade. She was 4 years old. It's spina bifida, and you see how rotten those teeth are. And then if there's nothing's done now, it's going to parlay into when they're adults, it's going to be equally as worse. So with a lifelong growth and development thing and guidance, try to prevent that. Besides the clinical stuff, there's always emergency care. Emergency departments, we have 10 residents that work here and there. They're not all on at the same time, but we provide call service for any emergency, for any of your patients that might have dental issues. Immediate stuff, because sometimes it's hard to get in to see me, or if they're dentists, they don't have a dentist. There's always somebody on call. Looking forward towards Christmas. I was there last year with a couple of special needs patients, Christmas Eve, Christmas Day, and Boxing Day last year. So that was a bit of an anomaly last year, but it happens. We're open 24/7, 365. We're on call for all of London and Southwestern Ontario. We even get calls from Thunder Bay because we are in that catchment area. So if in doubt, always call. And what do we see for emergency? A lot of trauma. Kids fall down, whether they trip and they fall, or they fall off the commode in the toilet, or they have a seizure and they fall and they break a tooth or something. And that could be the teeth, it could be the lips, it could be soft tissue, hard tissue. And then the other emergencies that we see is a lot of toothaches that we get called on. They can't find a dentist, and we're talking not just children, we're talking about the adults. And it's slowly moving to the adult side. If you understand the pediatric side, this is the adult side. You get this all the time. There's pain and swelling. Trauma is obvious. I talk about the one kid, Mitch. Sorry, I'm a storyteller. Somebody told me once. He was 16. He's 16 years old. He's 6'3", 180 pounds. He's bigger than me. The good thing is that his father's 6'5" and 270 pounds. He has an interesting syndrome called PitHopkins. He's only one in 500 kids around. I hope somebody might know him, so I'm not using his last name. But I always remember Brad Pitt and Anthony Hopkins. But he fell out of bed about 2 months ago, and Dad heard this big thud around 5 a.m. So he just went in there, it's pitch dark, and he just kind of threw him back in bed and stuff. But in the morning when he woke up, the parents said it was like a murder scene. There's blood everywhere, but they didn't realize at 5 in the morning. When he fell out of bed, he had broken off his tooth right up the gum line. Nerve was exposed, everything. So we had to, so we brought him in to emerge, and we had to figure it out. We tried to get him some OR time, tried to get some emergency surgery time to get that tooth fixed. In other words, take it out. In the end, he was quite funny. Like I said, he was bigger than me, but Dad was very good with him. We kind of just held him there. We got some laughing gas on him. We managed to do our little magic and little tricks, quick spurts of attention and distraction. Got him frozen, got the tooth out, and yay, victory for us, right? But stuff like this happens out of the blue, and that's a success story. But I could tell you so many failure stories, where they actually knock the whole tooth out on your left there, knock the tooth right out, or they break the bone that's above the hole in the tooth. Those are immediate. And this is a kid, same thing, special needs kid, I believe. He was very cooperative, but he broke off the central incisor, broke off the lateral, the central incisor, the nerves exposed, but he lost his canine. We couldn't find his canine, took an x-ray, couldn't find it, still couldn't find it. We patched his two teeth up, but we eventually found where this tooth was. It got buried in his lower lip, which was interesting because it wasn't up in the jaw there. It wasn't on where he fell. They couldn't find it, but it was in his lip. So we had to go fishing into his lip. And I just tell you this because whenever you're missing a tooth, if somebody knocks out a tooth, especially from a fall or trauma, sometimes we got to go looking for it because you always worry they might have aspirated. A little hard to see on this x-ray. This is not my patient. We've always talked about this. I've never seen it in 30 years. I've been a dentist for 30 years, but I can see my cursor. It's right around in his right lung, but most of the time it's in the stomach, right down on the bottom there. So that's why we have to investigate, because if it's in the lung, obviously we have to go after. You know, if it's in the stomach, hopefully it'll just poop it out. The other emergencies that we see are toothaches. This is Chris. He's a live patient. And so I've seen Chris since he was a youngster too. He's 26 now, and I think for someone when he was 5. He woke up like this, and this is September. He woke up like this. He's just autistic and developmentally delayed. He's a ward of the crown. His mother is not around in the picture. He woke up swollen, and sorry, on the left side. And I had a quick look in his mouth. And you got to understand, a lot of these kids haven't had any checkups because of COVID. I haven't seen these kids in 2 years. Right, so obviously he broke a tooth down here. You can see that abscess like that, the tooth needs to come out. So what I did was, a lot of infections are self-limiting and they drain spontaneously, but obviously he's got a cut in his cheek there. So I gave him some antibiotics. Hopefully that'll clear it up. As I tell the family, if you see something like this, get the antibiotics in there, but that'll clean it from the inside. But they got to clean it from the outside because otherwise it ain't going to work. Right. So I've usually prescribed a Mccallum. I can add some Flagyl for some anaerobes or clindamycin, but clindamycin can give you the poops. And if it's really more swollen, sometimes I go with clavulin, and that gives you GI issues too, right? So a lot of these kids have constipation issues and GI issues on top of are already there. You don't need something else to aggravate that or even add to it. So you have to be aware of the person attached to the teeth. And I've said that too many times already. So, but if it doesn't go, sometimes it doesn't get better, or they can't keep it clean. So he came back in October and November. So he's been back 3 times now. He's had 3 courses of antibiotics, and we got to get that tooth out of there. But we're trying to find an OR time and trying to do it. Surgery time, as long as he's stable, we're trying to find it. But I've triaged it. Normally, the wait time right now, if you need an urgent, well, not even urgent, any surgery, there all becomes urgent if you need surgery. Really, any patient does. It's potentially 6 months, but we got him in after 3. We had to juggle some things around, but we'll get him. I'm actually taking his tooth out on Friday. So, but if it does get worse, sometimes it gets really bad. So you got the whole face is swollen. You get into the periorbital region, under the throat where they can't swallow, or they have trouble breathing. Sometimes we got to put them on an IV. That means admission. When I was a resident, we admitted people routinely, and they would have to stay for 7 days. But we can't afford that anymore. There's no beds. Haven't said that. But if there's facial swelling, elevated temperature, they're dehydrated, they're not eating, they got lymphadenopathy, and as I say, a concomital. It's going to screw that up. Medical condition. So let's say you had a heart problem. He had heart disease, and you're worried about endocarditis. He would have been fixed like yesterday, but he doesn't. So we could afford a little bit of time. But it's up to us to triage, right? So this is one other patient. On the left there, you can see this lesion on the underside of the chin popped up, right? And interesting enough, 6 months ago, it happened on the other side. So 6 months ago, they called. Nobody checked the teeth, but they called ENT. Nothing against my ENT colleagues. They ended up putting her to sleep, did a neck dissection, tried to drain all of it. Couldn't get very much, but they couldn't understand it. But it's healed now a little bit. Okay, but 6 months later, this happened on the left side, but they managed to, the tooth is sore. Somehow she's nonverbal, but somehow they articulated her. They picked up on the fact that she couldn't eat well. So when you look in the mouth, this is after she's been intubated. Now you can see she had a broken tooth. And this is interesting. She had a broken tooth here, had an infection. It came all the way down into the mandible, went out of the mandible, and drained inside into. Now again, nothing against my ENT colleagues. I eventually had to go back and take the tooth out on the other side, but they never got the source of the problem. Because then it would come back, right? So we got the source this time. Just interesting things. So those are all the professional stuff that we do, and hopefully I haven't bored too many of the dentists. And hopefully, I always kind of joke that everybody has dental questions because it's so dear to everybody. Everybody's got issue. questions about potential issues and stuff. So what can we do from a preventive standpoint, right? I've talked about all these situations I talk about, or I suggest that my analogy is that there's a fire going on. So you've sought out a fireman to put out the fire. So what about smoke detectors and prevention? So we can get into that a little bit. And maybe this is the crux of it, or what we were going towards. We talk about routine care. I'm talking about non-clinical, non-emergency. These are the things you can do at home, mom and dad, or the group homes. Number one, we're going to talk to you about diet. Remember, I talked about all that stuff as I'm setting this all up, right? Talking about sugars and stuff. You know, water is the best thing for drinking. I understand somebody wants a pop, somebody wants a coffee, but moderation is the key. Because if you buy into the story, every time you had sugar, there's going to be an acid attack. You know, but and you may think you have 3 square meals a day, there's 3 acid attacks, but you have 3 meals, 3 snacks, and something before bed. That's only 3 plus 3 plus 1. That's 7 acid attacks. So that's where it comes, right? So you have to be aware of that. I put purees up there because some of these kids that they're choking, they don't have the motor ability to chew and swallow, and they choke on things. We cut things up. They have to have things cut up for them, or they puree things. Nothing like seeing a hamburger go right into a blender, freshly made hamburger, and then bzz, push them out, and then it's a liquid so they can scoop it up. But if you think of all the particulates, the little pieces of bits of sugar, now they're even smaller and they can get stuck in teeth even easier. And if you're already having a hard time cleaning them, or not doing it, or not being consistent, well, that's just a recipe for disaster, right? So this is where we lead into how do you care for teeth? And these are the things that can be done at home, and hopefully more at home minimizes my work in the clinic. Right? Toothbrushing, standard stuff. We all know this, whether you have special needs or not. Toothbrushing, twice a day minimum. Anything I say in between is a bonus, right? To get all that acid attack. The most important time is before bed, because you don't want any of that food that's been there all day sitting in your mouth there all night. Because that bacteria, they're having a buffet. They feel like they're at the Mandarin. They're just eating up all the debris, right? So twice a day. And then you want to get in the morning because anything you missed has been sitting there all night. Question is, do you use electric toothbrushes or regular brushes? It doesn't really matter in the end as long as the toothbrush bristles are touching the teeth. That's what I say. The electric ones definitely for dexterity and efficiency, definitely better as long as it's properly used. But let's face it, some of these kids, these patients with sensory processing issues, noises, they get freaked out by the buzzing. So I always tell the family or the support staff, go get a cheapy one. Get the $10 one at Walmart or Shoppers Drug Mart, and the ones made in China that are so rough and kind of brutal. And if the patient can tolerate that, then go buy a new one. Nothing against my Chinese companies, but they just make all the cheap stuff, right? But if they can tolerate that, then go get the fancy Oral-B one. Then go get the Sonicare one. The Sonicare is probably the ultrasonic. That's probably the Cadillac. And I've got one for Christmas. I'm getting my partner and her kids. They get Sonicares this year. But that will help with the efficiency and doing it, because there's some kids that actually love the buzzing. The autistic kids who love the weighted blanket. Sometimes they really like the buzzing. So why not use it? I have had questions about what do you call it? The water picks. Water picks are a great idea. To me, they don't work very well because they're basically just fancy squirt guns. My analogy to that is like washing the car with a Texas car wash. It looks nice from a distance, but if you really get close, it's not that good. So if you can use the toothbrush bristles on teeth. Toothpaste, of course you use toothpaste. Toothpaste has 2 functions. One is the fluoride, delivers fluoride. Not too much, because swallowing too much of that isn't good, right? The fluoride is proven to make enamel stronger. So it goes, when you're brushing, you disrupt all that biofilm, and you get the fluoride onto the enamel. It changes the enamel, makes it actually stronger. The WHO has said fluoride is one of the top 10 health improvements of all time, one of the best top 10 ever. So you want to get the fluoride on there. The other function of toothpaste is just the abrasiveness. Can you floss? Absolutely. I never set the bar low. I always suggested, at least, that kids should try, patients should try. My last picture, Kathy, she's about 37, 38 years old. She has Down syndrome. She flosses every day, and you wouldn't know that until you try, because she lets you. But don't get hurt, of course. But you can use those little flossers. There's a picture of it down there. And they use those tools. Okay. Mouth rinses. Over-the-counter stuff doesn't do a heck of a lot, but if it's adds to the routine, go for it. If that's what the patient likes, why not use it? Spend the $5 on a bottle but don't forget the brushing. The only mouth rinse that really is effective is by prescription is oral chlorhexidine rinse. right? And it's okay to swallow. Studies have shown that it's not absorbed that much. And swallowing, again, moderation once a day, maybe twice a day, but it's for the gums. And make sure you get the oral stuff, because I've had parents come back and said the pharmacist is giving chlorhexidine what they call it, in soap. So you're actually rinsing with soap. It gives a whole new definition to washing your mouth out with soap. So make sure it's the oral stuff. But the Paradex or chlorhexidine is proven to kill bacteria in your gums. Add that with a fluoride toothpaste on your teeth. Wonderful. That's great care for anybody. There are side effects to it, and that's per patient, right? Let's face it, honestly, a lot of times it's just a big smear. But again, something's better than nothing. I even suggest that sometimes maybe just getting a face cloth and wiping their face and just rubbing their teeth is still better than nothing. So that's a routine care. And hopefully that's just, well, the challenges are, you don't know what the patient's going to be like. I'm getting a lot of older patients who, in their history, they've been in an institution, they've been feared, they create anxiety. And I've heard horror stories about what's happened in institutions, and that's why a lot of their behaviors are bad. But we have to work on trust and repetitive action to hopefully the strength, the trust will come back, right? And a lot of these kids are getting older, they're getting more senile, their history, poked and prodded syndrome, I call it. How many times every time they see you because you're in scrubs or they look medical, they're going to just react because they think they're going to poke them somewhere. And some of these kids are huge, right? I put COVID in there too, because COVID has done a strange thing to this population because they've been isolated for so long. I've had kids that are actually excited to come see me now after 2 years because it's a field trip for them. They want to come, right? And social isolation has been awful. And that leads to the staff as well, because they're burnt out. And we have this in the hospital too. They want to get out and they're just tired. And that's led to shortages in staffing. So there's less people to take care of these patients. So that's a challenge too these days. From our perspective, the dentist, and it's not just all the parents, we easily say, hey, let's do it every 6 months. But there is a problem with us dentists. Getting remunerated is one big thing. It comes down to money. We have businesses to run. A dental office is a small business, and a lot of these patients are covered by the third one, the Ontario Disability Support Program, ODSP. So a regular checkup on a normal, healthy person with private insurance, we can charge about $230 maybe without x-rays. Ontario Disability only pays $96. Well, it's hard to keep a business alive that way. Over the long run, sure, it's doable, but you have to balance it. So it's a challenge that way. So that's why a lot of my colleagues, unfortunately, they say they can't afford to see a lot of these patients. I'm in a hospital, so my overhead is a little protected. And don't get me wrong, I like money too, but I have a balance of what I find acceptable. And believe me, I'm not trying to earn my wings or get a halo or anything with it. It's just my choice and what I decide to do. So if they don't have insurance, they have to pay this for out of pocket too. So that's hard. And so you're going to have a hard time getting a dentist. And then for the dentists too, they don't know what to do. A lot of the general dentists, they feel they haven't been trained in this, and that's true, because they don't know where to go. I'll use the Sick Kids model. At Sick Kids, when you turn 17, you graduate and you just go over across the street over in Mount Sinai. In London, we have nowhere to go. They just stay at the Victoria Hospital or whatever hospital. And same with if you have a kid in your practice or the dentist out there, they have nowhere to go. So you're hoping that if there's a general dentist out there who's willing to see the patient. And I don't ask general dentists to do everything. I ask them, I would suggest that if you can do the light lifting, do the checkup, have a look, make sure there's nothing bad going. But if there's something going on, then call me. Do the heavy. I'll do the heavy lifting, and that's what I'm there for, right? The hospital is society's safety net, right? So, but there aren't that many people out there, so it's hard to find someone. So it's this word of mouth that gets on the community. And maybe what Rob was saying, maybe people speak well of me because they haven't anything to compare it to. They find out that, Dr. Plosky's on, maybe if he was still practicing, they find out he's way better than me if he was accepting that patient. So, yeah. Sorry, Olaf, that's my self-deprecating humor. But everybody wants to come to the hospital, so we have wait times and only so many. So that bottom left picture is the program at Mount Sinai. As far as I know, in Mount Sinai and Toronto, it's the only program in Ontario that is specifically for adult special needs. And they have a waiting list of like a year to get in, and treatment close to that takes a year. And on the right side, I just take what my knowledge goes. That's to the right side. There's a picture of Grand River Hospital in Kitchener, because I try to do things there too, besides London. This just goes back to the dentist about lack of training. They don't know. The picture on the left, not to bore you out with those pictures, but it was a kid who had a special needs case. He's nonverbal, but pretty cooperative. He's nonverbal, but he would sit there to do treatment. So I let my resident do it, and nothing against the resident, but the tooth was really loose, so I figured just freeze and pop it out. I wasn't specific, so she just frozen. And if anybody's been frozen on the bottom, you can freeze it. You can freeze it either just around the tooth or the whole side, which it gets your whole jaw and your lip and your tongue. Well, she did what's called the block. She did the whole thing. I thought I was understood that the tooth was so loose I could just froze it around the area and would pop the tooth. Well, she froze the whole thing. The problem is that freezing lasted for 2 hours, and poor guy, he didn't understand it, so he started chewing his tongue. And the picture on the left there, you can see where the damage he's done. He actually chewed through his tongue to the point where it had to be sutured. And I apologize for the gory picture again, but the funny thing was it was the oral surgeon who decided to suture it up. But we managed to do the treatment in the chair to avoid a general anesthetic. But in order to fix the tongue, he had to have a general anesthetic to fix the tongue. So that was kind of ironic, or whatever the right word is. Yeah, and in the middle there, that's one of our nurses, Sue. She unfortunately, we're trying to escort a kid to the operating room, and the kid just reacted fast, bit her right on the arm. And if you can see, that's a big bite mark. And I'm glad it didn't go through skin, but Sue's a trooper and she understood what this population's about. But we always keep that picture as a reminder, we have to be safe, and it doesn't. And that's why we pre-sedate kids. And that's why some kids, these patients, they need to be under a general anesthetic before that happens. And sometimes I get in the way too. I had a 90-pound little autistic guy. He's about 5'2", 90 pounds, I swear. I don't know how he did it, but he just pushed. I'm trying to escort him into the bed, into the operating room, and he just pushed me back. Next thing you know, his left foot came up, got me square in the jaw, right? Knocked me right down. And we eventually got him onto the bed and stuff, but my TMJ still clicks. And this is from like 10 years ago. So for me, it's part of the job, but we can get hurt. Okay, so we always have to be careful, and that's why we talk about sedation. And actually, and that's why I tell these stories to parents and group homes. Hey, do as much as you can at home, because I don't want to go through a general anesthetic, and I don't want to get hurt myself. Nobody does, but we want to do. I'm lazy. I don't like to work that hard, but we're there if you need us. And part of the anxiety with the lack of training is that we tried to get. And I'm almost done here. We tried to get the young kids, the older dentists are kind of set in their ways. They don't want to learn stuff, but we try to get the young dentists. Try to get them exposed to this. The first special needs patient I ever treated, I didn't do it in dental school, is when I got to sick kids. And it was, again, what is it with these 6'3" child with autism? And the assistant literally pulled out this thing and it looked like a straitjacket. This is that 1991 when it was still kind of okay to do that. They had to put the kid in a straitjacket, wrapped his arms on it, they kind of guided him onto the chair. Dad, who's also very tall, he kind of straddled his legs, kind of held him down, and he just said, "Go for it." And that's how I cleaned his teeth. And then after that was his brother, who's also autistic, and I had to do the straitjacket thing. So in order to desensitize some of these new dentists to it, Sharing Smiles Day was created. It's a nonprofit charity thing. This has created chapters all across Canada. We have the dental students and the community living kids interact in the morning and do games and have fun. But then after we serve them a lunch, and then after we talk about teeth brushing, and that's how we get down to and make those connections. Now, hopefully all of these students are now more familiar with these kids and with these special needs patients, and they're not so anxious about it. And the perfect example is Dr. Mccallum. He was one of the residents. We did Night of Heroes for Community Living London. He owns Arcona, practice out in Arcona now, and he treats special needs patients too. And like I said, he does the easy lifting. He sends me the heavy lifting. And this was a kind of a fashion show fundraiser thing that we did. Ala is still a patient of mine. It's hilarious. And so I won't play the video. The video's down there. We're just dancing away. But that's the idea. And where would 2022 bring? Hopefully post-COVID. The Brantford Deaf and Blind group, they came down that want to say thank you for treating their kids, and that's Kathy. Kathy I've known for 25 years now, but it was her 20th visit that she finally sat in the chair. The first visit was in the parking lot because she knew what happened in hospitals and she wasn't walking in the hospital. So, but it took 20 visits. If you do the math, every 9 months, that's 15 years. For whatever reason, it took 15 years of patience and trying. Credit to her mom that brought her back on ODSP, brought her back on 20th visit. She finally sat in the chair. And I just saw her last week. We did a full checkup and she looks fine. And she's the one that we can floss. Okay. Sorry if that's long-winded. Okay. Try to keep it on time. Talked fast near the end because I knew I was running out of time, but hopefully I didn't bore too many people. But,
I think almost certainly the opposite, Raymond. I mean, I think that was a fantastic review about something that really most of us don't know about the hospital program, that we sort of hear secondhand and thirdhand or from parents or families. But it's a fantastic overview and of the difficulties that you see with some of these patients. And then I assume that a lot of them will be really difficult to treat in community dental practices just because of the need for sedation and things. So I think families certainly are really grateful for what you provide. Let me ask a question to start, though. So I think Leo Kanner, so the first person to describe autism in 1943 or whatever, I think he'd also written a book, though, about teeth in children with developmental problems. And I think sort of suggesting that teeth are commonly a problem in kids with developmental disorders stuff. I mean, what do we know about dental problems, like generally, or about teeth in people with developmental problems?
a lot of them is just oral hygiene because they can't brush and they can't, so that just exacerbates it, right? But then you get back into the diet. It's not the best at times, so they just do that. There are some developmental things like, I don't know, Down syndrome, and we always talk about Down syndrome because there's so many kids with Down syndrome, right? Sometimes they're missing teeth, sometimes they don't get teeth for a long time first, and then they're missing teeth and they don't change their teeth. So you got to watch that growth and development thing too, right? So, but autism, not really. That's more about oral hygiene practices and establishing routines, routine, right? You know all about that. And trying to get them and desensitized to what I do, at least. And it takes a lot of persistence and consistency.
Yeah, and I think that's really difficult for families sometimes, and it's.
Really?
I think sometimes families find it easier. I hate to say it, just not. I've seen certainly several families say that it's just easier just not to get into fights with their kid about brushing their teeth, which of course is not the right way to go about it.
No,
because it creates all kinds of other problems for them.
right.
So there's something here from Alicia Thatcher. Let's see, she wrote, thanks for the excellent presentation. The Commission on Dental Accreditation recently passed a motion requiring all U.S. dental schools to now train their students in managing treatment of patients with intellectual and developmental disabilities. Do you know if there's any discussion about creating a similar mandate for curriculum in Canadian dental schools?
There's a lot of talk. The accreditation group, I used to be more involved with them, but I don't know that they're doing that. The problem is getting everybody on the same page and keeping the momentum with anything like that. The Americans have been very good as a group. That started probably back in 2004 when, the Surgeon General made a lot of those statements and he mandated that it had to be done. And honestly, a lot of dental schools got a lot of money and they said, use it or lose it. And so they created these programs and it took about 2004, 15, 16, 17 years before it comes to fruition. We would love to do that in our universities, but that's why there was that need for that, the oral health, total health. They're just projects on the side of, it was just an extracurricular activity for Dr. Siegel, the younger Siegel Jr. And I try to advocate as much as I can, try to teach, but there is no formal thing right now. I would love to see it. I don't know if it's going to happen in my time, but we would need all the schools. Unfortunately, there's not a whole lot of faculty to teach them either. So there's only one of me, and every school doesn't necessarily have one of me because you don't want more of me. Not everybody loves Raymond.
I'm not sure that's true, but so Jennifer McLean is a pediatrician at Thames Valley Children's Center and here at CPRI.
Yep.
And she had her hand raised, but is now lowered. But Jennifer also asked a question in the chat here. Says, that she said, first of all, it's a fantastic presentation. Thank you. But also, so that many parents are scared to take their children to the dentist because of what might happen and the concern that their children won't sit in the chair and won't stay still. I mean, do you have any suggestions or what we can tell parents of kids with those kind of difficulties?
I kind of go back to, like, I don't want to lower the bar, you don't know until you try. I hope that, I can't speak for anybody else, but I think we're all pretty understanding of the situation if we just get a heads up. I've had parents come in beforehand, take pictures of everything, take a picture of me, desensitize the kid to it. And like I said, with Kathy, my first visit was in the car. I'm not professing I do that all, especially when it's cold out like this, but Well, I'll put a jacket on. Hey, nice to meet you. We could meet somewhere. We could meet in the waiting room. We could meet in the cafeteria if we have to. And sometimes you need that desensitization. I understand there's that anxiety and the fear. Hey, in a way, you know, I sometimes see that big kid and, you know, I see if I look in their eye and I'm a little intimidated, right? But you kind of got to walk in the room, and I think to give kids a lot of credit. I give them more credit than I'd rather fear. I'd rather hope for the best as opposed to fearing the worst. But that's just my attitude, and the parents, as parents, they're looking out. I understand they're advocating for the kid and they're looking out for them. They don't want to fail. Nobody wants to fail, but it's a lot of times it's a personality thing. And there's patients, like I said, don't love Raymond. We don't get along, and the anxiety comes out, but you don't know until you try.
But you know, I think that's a great point about trying, because I think we see parents who have been, you know, had so much difficulty that they're just afraid to try new things. And in fact, going back to Canner, I think he wrote that in describing autism early on, that, you know, kids with autism have a lot of routines and ritualistic behavior. He then went and said, you know, but parents of kids with autism often also develop a lot of routines and rituals. Because they don't want the child's routines and rituals being changed. Right. And so you sort of get things just sort of snowballing. So Jennifer, your hand is still raised. So let me allow you to talk if you can unmute yourself.
Oh, wow. Somebody live.
Thank you. Yes. Hi.
Hi, Jen. How are you?
Hi. Pretty good. We often share patients, as you're well aware.
Yes.
I think one of the hardest things is trying to talk families into bringing kids in. And this is a constant battle I'm dealing with, because they've had very difficult situations with other experiences and with their own experience of not only other clinical appointments for the child, but for them, even just in toothbrushing, and they're embarrassed that they cannot brush this child with special needs teeth compared to their other children. My one question I wanted to ask was, do you use child life or social stories to try to help the anxiety situation, but for both, not only the child or youth, but for the parents?
Is that a parent, that parent's attached to that kid, right? So
yes,
I have. Yes, I have. And sometimes I've had a couple of kids that actually prefer the child life work person over their parents. So, you know, they've established a very important part of the system, and if they can help, I'm more than happy to have them help us all the time. And we do have, I think we have a good relationship. But you're right, we have to try to help the parents, you know, want to get help too. Like I think they do, but they're just
it's the anxiety of both. It's the perceived anxiety of what the child's going through, but the anxiety is really high with the parents. Because
you never know what they've gone through, right? And I call it PTSD, right? And this is where I suggest to parents too, like if you know they're having an MRI or CT, you know, where the kid's sedated, I have to do this tomorrow. The kid's having a biopsy done. Say, hey, can you go in and take an X-ray? Can you have a, sure. Oh, well, not sure, but I had to rearrange my schedule. I'm not going to take lunch, but you know, at least then we can get a baseline, right? And that every little baby step hopefully will build up into something. So, yeah.
And my last is a really quick question. For children with special needs and children without special needs, what age would you say they should start seeing a dentist? Because there's a lot of controversy out there by the families going to community dentists and being told, don't come to us till the child's 4.
Yeah, I've heard that too, right? So the Canadian Academy and the American Academy, and the American Academy of Pediatrics is considered the standard, right? And Canadians, we kind of adopted it. So why reinvent the wheel, right? The general rule is within 1 year old, at 1 year old. But the problem is you're going to have a hard time finding a dentist who's comfortable seeing a child.
That's the point, yeah.
So that's why
that's exactly the point.
We used to say 3 years old all the time, because that's when the children got all their teeth, number one. And then there's a reasonable expectation that they would sit in the chair, right? But as pediatric dentists, we would see so many kids that were less than 3 already had a disaster in their mouth.
Yeah, well, and that's what I say to the families. I said, if I'm seeing anything at all, right, there's obviously more there that I can't see. Exactly. And that's enough reason to get them in to see the dentist.
Right. And I'm trying to teach the pediatric medicine residents. They rotate with me too. And Grace Bravo, who's on staff now at the Peds Emergence, she said it to me. She was one of the very first. You know, we're taught to go into the mouth. We go right for the tonsils. I've learned that we got to slow down, look at the teeth first, take a quick look, and then make that referral if we need to.
Yeah, start from the front. Start counting them at the front. Most kids will let you look a lot if you do that. Yeah. Make it fun.
Yeah, we tried, right?
Yeah.
Why do I get a feeling I'm going to get a whole bunch of referrals too?
But I'm trying to get them out to their community dentist first to do the initial, because if they can get an initial, first of all, they get used to being there. But second of all, that's sort of like that, you know, the first tier to then, if
Mhm.
there's anything there, then they get to you, right?
Right, exactly. What if they already got a cavity? Well,
Yep.
then they can talk about the bottle and say, you better get that fixed now before it
Mhm.
becomes a real disaster.
That's right.
But again, you're gonna have a hard time getting the dentist to be comfortable with it. Hey, just have a look. Oh my God.
Mhm. Mhm.
Now, one thing COVID has happened is we've had to quote unquote pivot. We've doing this virtual stuff. So I've gotten consults now. I'm just doing over the phone. Parents take pictures.
Mhm.
They take as many pictures as you can, send it to the email, and we can do a virtual consult. You're not going to stick an iPhone into a 1-year-old's mouth, but that's sometimes better than nothing. So
I just had a wonderful vision of getting those pictures. Yes. Okay. Well,
do it when
thank
they're
you very
sleeping.
much, Dr. Lee.
Yeah, good to hear from you.
So, Raymond, there's a question that was asked in the Q&A. So do you have any suggestions for people working in dental offices who are interested in seeing people with developmental disabilities or are more than willing to do so, but the expectation of the office in general is that people should be referred to the hospital?
Sorry, I missed that first part. They just
So people who are working in a dental office in the community,
office,
yeah, and are more than willing to see people with developmental disabilities and would like to, but the general office policy is that such people should be referred to the hospital.
Well, I don't necessarily agree with that because anybody can look. Easy for me to say, but a lot of times it's if you think about it, it's your own anxiety as a clinician, as a doctor. Maybe you're anxious about saying, can you just have a look? And you'd be surprised how I would say to them how cooperative some kids are. And
But so I
instead
think
of
this is
just
from somebody working in a dental clinic who would like to see people, but the office policy, I suppose,
Mhm.
is to not see such people. Is there anything that they could say to the people who run the office that would help?
Yeah, I see that's a personal, like, why wouldn't they see them? You know,
I don't know.
that's, and especially if you're just a clinician and you're not the owner per se, they're signing your paycheck and what are you going to do? Right. So, um, I'm very careful who like, I can't fix everybody. So, I'm kind of careful. I'm kind of picky about what we see, but usually there's a story there and I'm not that picky, honestly. I just want a kid to get fixed, especially.
And
But
I
I have
think
my
somebody-
friends. I know my people that I know certain people that will see these kids and other ones that don't.
Well, and I think some people, I think because sometimes people with developmental disabilities are impulsive or act erratically, I think that frightens some people, and so they're really not sure what to do. And I would
Absolutely.
imagine, so I would think the reason, if anybody is unwilling to see people, it's probably because of a lack of experience or lack of knowledge
Their
more than anything else.
their own anxiety, right? So
Yeah, as opposed. So someone I think you may be familiar with would like to speak. So Dr. Plotsky,
oh,
if you could just unmute yourself there, Olaf, which you've already done.
hey Olaf.
How are you? Can
Great.
you hear me? Okay. So when you look at the definition of pediatric dentist, and we know the age limit, and yet both the American Academy, Canadian Academy have, and all people with special needs of all ages, that we know there are jurisdictions in North America where there are cutoffs even for pediatric dentists, even though
Mhm.
it's such. We also know that as a pediatric dentist, you've always got kids coming in at the early age, filling your practice. At some point, there will come a sort of a self-limiting factor where you cannot continue to see the adults with special needs. So we know there are barriers in place. Do you have any suggestions outside of education per se that we can look at from your perspective and 30 years of experience that could get family dentists to start to see these patients?
Not well, anything short of giving talks and trying to educate them and trying to convince them of that. You've seen me. You've been at this longer than I have. Just trying to convince people that they can do it. I that's why I'm starting at the beginning. When they're still students, right, and getting the residents and trying to provide them and give them the confidence that they can do some of this stuff. But it's hard to teach. No offense to anybody, but it's hard to teach an old dog new tricks. And again, then it comes down. There's all these excuses. They're not comfortable. They're not trained. They don't have any. It doesn't make sense in terms of the business. Let's face it. A lot of these patients need more work, and they pay the least. So there's the business side of it too. And especially now with the COVID and the backlog, they're trying to get through a lot of other stuff. But unfortunately, it's these patients that need a lot of the work, right? So. That's all I tried to have my group core people that I know that will take them, and it's usually from working with them. And just like the medical side, you guys know who I am and you know what I do, and we try to build that way. but it's hard to fix everybody, so I'm not sure I answered your question, but it's hard.
No, and I don't mean to hog the scenario here, but we know that at least 15% of the Canadian population has at least one type of disability. Areas they are saying up to 20%, which means 1 in 5 Canadians has a form of disability. And unless family dentists start participating more actively, we're basically ignoring 20% of our population that has oral health care needs. And it's a problem that's growing. And it seems that the answers are not, or the challenges and barriers are not being met head on. And the common complaint always is that we don't have the money to deal with it.
Right. I look at the Americans, what we were talking about before. 2004, 2005, whatever it was the Surgeon General who made it an important topic, and they threw the money out there. So I hear things, and I was a member of committees for the ODA, the Ontario Dental Association, Canadian Dental Association, but I never see a lot of action, so to speak. I don't know a lot of the stuff there, but I'm not involved in it. So that's where the advocacy comes. You never want to go to the press about things, but but it's a grassroots thing that it doesn't seem to have a lot of foundation there and momentum, and it's a struggle because the dental schools are there, they're ready. We just need to do it, and it's got to start.
Final comment, and again, could you possibly mention CSDH as a resource that people can access?
Oh, sure. What's the website again?
It's lowercase csdh.ca. All lowercase.
Canadian Society for the Dentistry for, what's the H for? Sorry.
Oh, no, Canadian Society for Disability and Oral Health.
Yes, okay. So that's it's part of the international group. It's an affiliate of it. And Olaf is president, and it's hard to get started, isn't it? So what, even 2 years now? Trying to keep that momentum. It's a great resource, and 300 members now?
Close to it, student and what we call Class 8 paid members. So we're working on it, and anybody who visits the site can see what kind of resources are out there and what we're trying to do, along with education and funding. So answers are to be had, just need people to access it.
Yeah. But and certainly we can sort of try and spread that around to family doctors and pediatricians that we encounter. So I think that's it's a huge question, and how do we help people with dental difficulties and other disabilities? And it sounds, from what you said, I mean, it's grossly neglected, and it's just going to lead to many more problems down the road.
Exactly, right. And especially now with the resources, like, with COVID and everything, it's been difficult to get operating room time, do sedations, because I feel like we're always behind the 8 ball trying to put out a fire, right? So and we have to put out the fire, before we talk about smoke detectors and not smoking in bed and all that stuff. And all my analogies, sorry, just to repeat it.
So just keep up the good work, Ray. Take care.
Oh, thank you, Olaf. I was taught by some of the best,
So just and to put a plug in for Dr. Plotsky, not that he needs one. So in March or April, I can't remember which, and Sarah, you can correct me, but we have our annual continuing professional development afternoon, and Dr. Plotsky will be talking. It's largely for primary care physicians, but Dr. Plotsky will be speaking about dental care there, also people with disabilities. So hopefully we can see people there. So Dr. Goldberg, who is, I don't want to say the founder of Developmental Disabilities Study in London, because that makes him sound older than he is, but it certainly is one of the people who's been working in this field for a lengthy period of time. And so, Dr. Goldberg, you had a question. I will let me put here allow to talk. You just have to unmute yourself.
Yes, can you hear me now?
Yep.
Okay. A very comprehensive presentation. Many years ago, in my day, Dr. Clive Friedman arranged funding with the government to have a group, himself and a group of dentists participate in a dental program associated with the Special Olympics. This was with pre-COVID days. It seems to me that this is a wonderful opportunity once COVID disappears to reinstitute a program like that. Now, I suspect that most of the participants in Special Olympics are individuals with Down syndrome, but it is a wonderful way to introduce dental care. So I'm wondering if something similar can be thought of in the future or currently. Any thoughts on that, Dr. Lee?
Sure. I remember participating in that. It was in Hamilton when I was a resident, so that was 94. And then wasn't Special Olympics just here in London? So I remember doing screenings, and we did find a few cavities. I remember that, but it was quick in and out. But I think that's kind of goes with what Olaf was saying. You know, we have to be out there and present, and to keep this on the front page, so to speak, right? I don't know what's happening with Special Olympics right now, because well, COVID is always an excuse for something, but I don't know what happened since then. I think the Olympics have moved around, and I remember thinking though, whenever the Special Olympics was here in London, I didn't hear anything about a dental screening. And I remember thinking, I wonder why that isn't. Or maybe it happened and I wasn't involved, which is fine. I don't need to be involved in everything. But if there's an opportunity there, we just need somebody or some group to take that spearhead and to advocate for it. And maybe if Olaf is still listening, CSDH would be perfect for that. They could a joint partnership, you know, affiliate together. That would be perfect.
I think you would be the ideal person to initiate it.
Who, me? Oh, thank you for that confidence. I'm busy. Well, when I get that master's in healthcare, I can supervise. Well, if you know the contacts, you know, I see Olaf. I don't know if Olaf's hands up on purpose about this or was there before, but you know, sure, have no problem with that. And I haven't talked to Clive in a while, but I don't know if he has more information on that, if he's still involved with it.
But I think, and Dr. Friedman, I think used to actually have a clinic here at CPRI, and I think with funding cutbacks or whatever, it got closed down. But which is a real shame, because I think for families, if we really want to make things accessible, you know, having everything in one place, especially with people who know the child or adolescent, will make a huge difference.
I call that one-stop shopping. Be great. Well, that's what the hospital is. The hospital is in a way like that. They have all the other services, and that's why I go out of my way to make myself accessible.
But so you're out in the tower. So is that the E section?
Yeah, E tower. Yeah.
I think it's the corn, is it not? Is that it's when you look at the things on the wall, because they have everything is like there's a ladybug section and this. I think it's the corn, because I used to because I used to have an office at the very end of one of the hallways in the professional block. It was as far away from the hospital as you could actually get. So I don't know what kind of sign that was for the people administering the hospital, but apparently they wanted me as far away as possible. So
same with, wow, you sound like a dentist.
Olaf, did you have another comment or a question?
Actually, I just wanted to let people know that the Canadian Society for Disability and Oral Health actually have a memorandum of understanding with Special Olympics Canada.
Oh, there you go.
Process of collaborating with them and getting students involved, and also identifying individuals of the process of how to become a director. And so we're very actively involved. And just for Dr. Goldberg's sake, just to let him know, Clive Friedman is still very actively involved in this process. And he's also on our board of directors for the CSDH as well. So Special Olympics is live and well, and we're working with them, and we're trying to carry it across Canada.
Awesome.
So, you know, I think, Raymond, the number of people who've stuck around and had questions and comments, I think says a lot about the interest that your talk created and the quality of it. So, you know, I think it's fantastic, and we need to have more dental people come and talk with our group. And so I appreciate you being the on the vanguard of that. But this was a really fantastic talk, and I appreciate what you've done. It's wonderful. It's really helpful to everybody, I think. So thank you.
Well, thanks for inviting me. Thanks for having me. Yeah.
Absolutely our pleasure. So when people close the browser, they will get a link for the evaluation. So please complete that. It's really helpful. And I'm sure it'll be 7s or whatever the highest number is across the board. But then also Sarah will send people the continuing continuing professional development certificates. So our next session is in January, and Sarah told me the date, and I've completely forgotten it, of course. It is January the 12th, and Professor Dr. Julio Martinez will be talking that day. So we will send out the notice earlier, but we look forward to seeing everybody there. And thank you for everybody today. And thank you again, Raymond. I think this was a fantastic talk and a great opportunity for all of us. So thank you.
Thanks for having me. Okay, have a good day, everybody.
Yep, we'll be in touch. Take care.
Okay, thanks.